said to you, what I want everybody to commit to is just listen until the end of the presentation. There's a punchline, I promise. And it's worth it, I hope. Let's start out with just something we all know, right? Out of hospital cardiac arrest, time is muscle, and it is important to defibrillate as soon as possible. That's actually not true. It's a huge study, the OPAL study. It was actually started in the late 90s and it continues in some form even now. And one of the interesting things about the first part of the study, it was a big study, and it showed that actually you have to defibrillate within 6 minutes, but it doesn't really seem to matter as much whether you do it at 2 minutes or 4 minutes. As long as it's in 6 minutes, there's a pretty steady rate of survival. Then from 6 minutes to 11 minutes, there's a steady decline. It's a pretty massive decline, as you can imagine. And after 11 minutes, the odds are extremely poor, but they're flat. There's not really a difference if your first defibrillation takes place at 12 minutes or 15 minutes or longer. It's a pretty flat, universally bad outcome. So for those of you that this was new information, I want to ask you, how did it feel? You learned something new about CPR and defibrillation, right? I told you something. I gave you where I got it from, and I'm a credible source, I hope. Hopefully you believe that what I just stated. Matter of fact, I'm pretty sure that no one's really upset by anything I've just said. And actually, I hope that the next time you guys are hanging out and somebody talks about time to defibrillation and how important it is, you kind of correct them or talk to them about it, and you discuss your newfound knowledge. Knowledge shared is knowledge earned, right? But what if I told you that the study also found that advanced life support interventions did not improve the rate of survival after out of hospital cardiac arrest? And if you have your system already maximized for rapid defibrillation, defibrillation is the only thing that counts, and all those ALS initiatives do nothing. Same study. How did it feel to have that fact? Any friction this time? Now, don't get me wrong. I want to stop right now and tell you that this is not going to be a talk about whether or not ALS works or doesn't work. I am not here to go through a bunch of literature to show you that ALS works or ALS doesn't, because let's face facts, we can argue any point of anything. I don't care. Okay. What the point is of today's talk is not whether or not ALS works. That's the vehicle for a moment. What I want to do is to give you a sense of how you feel when you're presented with new ideas. And we need to make a distinction between new ideas that challenge and new ideas that don't, because I'm pretty sure that the first fact that there's really not any difference in time to first defibrillation once you reach a certain point, I think we all pretty much knew that dead is dead at a certain point. And I think we all can pretty easily accept that there's a period of time where there's enough oxygen flowing around that there's probably not that much difference between 1 minute and 3 minutes when it comes to defibrillation. So that's an easy fact, and I'm pretty sure that most of you, okay, you took it. But that second fact, and I'm pretty sure some of you were like, okay, wait, what's that study? Hold on, ALS doesn't, no. I know that ALS works. Matter of fact, I'm glad that I don't have my Twitter open right now, because I'm fairly certain that there's probably at least one or two people that have already blasted me and told me what an idiot I am, because absolutely ALS works. They've got 16 times that they can show me, and they've got about 20 different studies. Okay. So that's part of it. Take a deep breath. Let's try a few more of these for a minute. What if I told you that EMS is actually older than emergency medicine? The first licensed paramedics actually predate the first board certified emergency physicians. And it's not by a couple of years, because the first board certified emergency physicians didn't occur until 1979. So it's not a subtle difference. What if I told you that EMS was actually created solely around car crashes? The very first thing that happened was the National Academy of Sciences released a paper. It was Accidental Death and Disability, the Neglected Disease of Modern Society. And they lamented the fact that somebody who was in a car crash on an American highway had a much lower survival rate than somebody who was shot in the jungles of Vietnam. And that was an impetus to things. And one of the first, at the time, it was the National Highway Safety Board. So it's not a misspelling, the NHSB. One of the leaders was Dr. Haddon, and they introduced the Haddon matrix, which actually completely described how we would deal with car crashes by improving cars, improving roads, and having paramedics. Their focus initially was solely on let's get car crashes to be survivable instances. What if I told you that some states allow high schoolers to respond as EMTs? Now, for some of you, that may not be news. That may have been how you started, and if so, that's awesome. But high school and college-based EMS systems have a long-standing history. All right. How do you feel after those facts? I mean, they're pretty easy. I don't think I'm challenging anyone's preconceived notions there. Let's try a few more. Pretty decent studies out there that show that advanced life support systems do not decrease mortality or morbidity for major trauma patients. ALS is ineffective in trauma. Firefighter paramedics can be effective. I am one, so I happen to think they can be very effective. And I suppose I could flip this slide and say that they're not effective, because there's two sides to every argument, right? What if I told you there's racial disparities in EMS pain management? That we do a horrible job with Black patients, and that we treat them much less with pre-hospital analgesics than we do white patients, even if we control for all other variables. How'd those last three feel? Anyone's head ready to explode? I'm pretty sure some of you are absolutely convinced that I am here to just bash EMS. Okay, so we can concede that you feel differently when we start to say that we're not treating our Black patients right, or that we really don't have a role in trauma, or I think those are tougher things to get than, hey, listen, emergency medicine is a young field and EMS is a young field, but it's older than EM. So why? Why are some of those things easy to accept and others aren't? Why is it that we really get a visceral reaction to certain things? And I'll tell you, I didn't even get into my triggers, man. You get me on a subject of helicopters someday. And I'm a flight doc. I served years on Cleveland Metro EMS helicopters as an attending. It's the best job I've ever had. I'd go back in a heartbeat. I didn't even hit my triggers because I don't know that I could even do it well. So why? Why is it that when we're presented with this data that we just dig in? And the more data that we get, actually, the more we hear about this stuff, the more that somebody shows us that these things that bother us are true, we actually start to really push back harder. Why would producing more evidence make somebody less likely to believe in the idea? I mean, this is crazy, right? I mean, this is like legit flat earth, tinfoil hat. I show you more evidence and you get more upset, not more convinced. But there's actually a reason for it. It's a thing known as the backfire effect. And really what it has to do with is the fact that we haven't evolved from cavemen. These really smart group of neurophysiologists did this study in a functional MRI machine, and they basically took people and they started off by asking them their political beliefs. They threw them into this MRI machine, and then they gave them examples and arguments that were counter to what they believed. If somebody was very to the right of the political spectrum, they started to talk to them about laws restricting gun ownerships. We should have more laws for gun ownership. If they were somebody who identified as very liberal, they went into this whole discussion of gay marriage shouldn't be legalized. And then as the participants were bombarded with these arguments, they saw which part of their brain lit up. And what's interesting that they found is when you get into some of these deeper ideas, the part of the brain that lights up is not the part you would expect. It's the part of the brain that responds to a physical threat, not to an intellectual one. The amygdala, which is our fight or flight reflex. It is the part of our brain that tells us that we are in danger, that something bad is happening, is what lights up when we deal with these deeply challenging ideas. It's the same spot that lights up if somebody points a gun at you. Now, the prefrontal cortex is what we would have expected. That's the area for learning. That's the area that probably lit up when you were given a new fact that you don't have a preconceived notion about. But we're legitimately, biologically wired to react to threatening information the same way we'd react to being attacked by a predator. We haven't evolved from being chased by saber-toothed tigers. We have one system when we're stressed. And it doesn't matter whether that stress is being chased by a saber-toothed tiger, whether that stress is losing $1 million deal, whether that stress is breaking up with a significant other, or whether that stress is having an idea that is deeply held challenged. From an evolutionary standpoint, right, this makes sense. We don't want to sit and have a debate when somebody is trying to kill us. And we haven't been communicating and functioning as a society long enough to really have evolved, right? I mean, evolution is a millions of years thing, and we're thousands of years into what we would refer to as civilization. So when we hit our core beliefs, those beliefs that we hold deep, those absolute truths for us, right? When we hit those are inflexible. Those aren't things that we change. Those are who we are. And so when I told you that after a short while, time to defibrillation really doesn't matter, that didn't bother anybody. That's not a core belief. Nobody's vested in that. But when I suggested that ALS may not improve out-of-hospital cardiac arrest outcomes, whoa. Now, the reason is obvious, right? Out-of-hospital cardiac arrest is what we do. It is pretty much our reason for being there. And then I went off to trauma, right? Because if it's not trauma and out-of-hospital cardiac arrest, why are any of us here? But the reason that we reacted that way is biological, right? The amygdala is telling us, oh my gosh, it is time to gird for battle. It's time to fight. You cannot say that about my skills. I am an ALS provider. I'm an emergency physician. I am a BLS provider. You are not going to take what I do and tell us that doesn't work. Time for battle, baby. Bring it. So most of us hold the worldview, and I'm one of them, by the way, that paramedics are very effective. I personally believe paramedics are one of the best public health interventions ever. But if we present negative information, we challenge that worldview. And the problem is our brains don't like that. We like things to fit. We love it when everything just matches up. And when something doesn't fit, it creates a legitimate dissonance. Cognitive dissonance is uncomfortable. It's almost painful. And that's the challenge, right? Because that's why we have the backfire effect. We don't want to be sitting there in a classroom and suddenly feel as though we're being chased by a saber-toothed tiger. We don't want our core beliefs, our reason for being, to be able to be destroyed in a couple of words from an instructor we trust. And so we have to create this barrier. We have to create this way of dealing with that in order to hold those beliefs. So we create the backfire effect. It's our way of protecting our worldview. But what we have to try and remember is that our worldview isn't a perfect house. It's not always the right answer. Now, what do we do about this? I would hope that somebody out there is waiting right now for me to give you a whole series of creative, clever ways that we can realize when we're in the backfire effect and get out of it, right? Here's what you do. You take when you realize, no, I don't have that. I mean, yeah, there are ways of changing people's minds that are more effective than others. But ultimately, they all fall short if we're trying to address somebody's core views. Now, we're not going to, by the rules of today's conference, we're not going to mention the disease that shall not be named. But I think we're all experiencing this a lot as we try to change people's minds on social media today, or any day, really. There ultimately, a lot of things fall short when you try to change somebody's core beliefs. And then you compound it with the internet, right? Because everything is a source. And every disagreement basically boils down to us being a bunch of chimpanzees and throwing feces at each other. Okay. So where do we go? What I hope, before I go to talk about how to look at things from a broad spectrum, is to make you aware of the backfire effect so that you can identify it. And that's not easy. The mind can't separate the emotional cortex from the logical one. The mind can't separate the emotional cortex from a logical one. So when I'm challenged personally, what I look at and what I hope to do is to let it fight. Let my emotions tee up. Let them debate. Let them tell me how crazy that idea is. And then try to listen. And then try to change. I try to change. Now, my wife laughed when I was preparing these slides. She said, "You're the one giving this talk?" But it's something that I've noted in myself over the past probably year, that I'm really trying to be aware of when the backfire effect hits. I think the woke people call it being triggered. We need to be aware of it, because we're all in this together. And I'm not here to try and tell you how to change everything. As I said, the reason I brought up ALS is not to convince you today that ALS isn't effective. It is. I'm not here to tell you what to believe. What I'm trying to do is to tell you that it's okay to stop the fight. It's okay to listen to an idea that is contrary to what you've always heard, to what you've always known. It's okay to listen to it. It's even okay to change those beliefs every once in a while. Now we'll move to part 2, since we've decided to open up our minds together, assuming that I haven't lost the entirety of my audience at this point. For those of you who are interested and still want to debate this out, the list of references can be provided for you as to where I got those quotes about EMS history or for fights. But let me switch slide sets real quick here and move on to another portion of my talk. Bear with me, please.
Hey, Dr. Mell, we're not getting any sound.
Oh boy. All right. Well, then I will just go ahead and move forward. So, what the video was supposed to show was people being afraid of quicksand. And for those of you who haven't seen the movie, it's a movie where football players kind of return after long absence from the field. And one of them is talking that his biggest fear is quicksand. And the other players start to talk about, well, yeah, quicksand is scary, you know, and they're talking about physical quicksand, but that's not what the player was talking about. What he was talking about is he says, you know, it's like when you're playing in a game and everything's going fine, and all of a sudden one thing goes wrong, and then another, and then another, and then another, and then you pretty much can't move, and you just seem to be drowning and ending up in quicksand. And it resonated with me because I think we've all had that call, that case that confounded us. And it just seemed like every time we turned, every time you tried to change something or do something different with that case, you couldn't. It just became too much. And so I tried to figure out a way, how do you undo that, right? How, when we're getting just swamped by a case, when nothing seems to be working the right way, when nothing seems to be going how it was meant to be, how do you stop and undo and get out of it? Anybody out there, hopefully, don't know if anyone's shouting at the screen right now, but this is John Boyd. John was a very unique pilot. He helped to design the F-15. He helped to design the F-16. Even though he was a pilot, he ends up really helping to write the manual for the U.S. Marines doing amphibious assaults. He was one of the people who helped develop the idea of shock and awe when in the first Gulf War. So he's kind of a unique person. And he came up with this thing called the OODA Loop. Observe, orient, decide, and act. Now, it's interesting because just about every business school on the planet teaches a course in the OODA Loop. And everybody discusses the OODA Loop. You may have had classes on it. You may have seen this in any of the quality improvement, practice management stuff that's out there. And what's really interesting is John Boyd never actually finished the OODA Loop. All of the descriptions of it, all of the discussions of it actually come from his notes and notes of people who were at his classes. He never wrote a book on this, but yet everyone teaches it as though they have. Now, this is actually pieced together as the full kind of John Boyd's OODA Loop if you take all of the parts of it, but it gets taught in different ways and often much more simple. Now, John, if we look here, it breaks this whole thing up into how we interact with things. It really starts off with having a mental model. We're going on a call. And we've been taught, and one of the problems with even looking at how we think is we have all been taught that mental models are preconceived notions, and preconceived notions are bad things. And that's not necessarily true. Mental models are okay if they help us predict human behavior. Now, when we're talking about predicting human behavior, it's one of the things that annoys me more than anything. Whenever you have a mass murderer, whenever we have a serial killer found, they always have the same thing, right? They interview somebody who is a neighbor, and they said, we never could have predicted this. They talked to their school teachers, we never would have predicted this. You know, and then you'll have a bunch of people, oh, this could have never been predicted. We can't predict human behavior. Horseshit. I drive to work. I take a 4,000-pound vehicle, hurl it down a highway at a mile a minute, surrounded by other and sometimes bigger pieces of metal, hurling down the highway based on what? Human prediction. I'm predicting that the guy in the car next to me isn't going to suddenly swerve into my lane and kill me. I'm predicting that when we come to a red light, everyone's going to stop. And a green light, everyone's going to go. There's nothing that physically prevents somebody from running through a red light. How do we decide? We predict it. And actually, when we drive, we make no excuses for prediction, right? Nobody thinks bad of somebody who sees a car weaving all over the road, driving like a maniac, and intentionally gets away from them, turns away, drives in front of them, lets them get in front of them, whatever they've got to do to avoid that. Nobody thinks bad. But if we take an action to defend ourselves based on a perceived threat, all of a sudden it's, well, wait, were we doing this for the wrong reason? Right? Women get asked out by a guy who creeps them out, and they say yes because they want to be nice. No. If you're getting creeped out, there's a reason. Don't say yes. Don't have to worry about it. You can predict human behavior. We do it every single day. So what John would say is that you take this OODA loop and you take your observations and you take all this outside information and you create. Now, when he wanted to create this OODA loop, when he sat back to think about how we should interact with all of our surroundings, what he did was he took three seemingly detached theories from different math and physics and the like. And the first one he took was Gödel's incompleteness theorem. And Gödel's incompleteness theorem basically is the statement, it's a paradox, right? This statement cannot be proved, right? This statement is a lie. It can't be solved. There's actually, if you look on the screen, there's a mathematical statement that actually is an unsolvable, pure mathematical argument. But basically what we're trying to say, what he was saying and what Gödel was saying is there are certain things that just cannot be proven one way or the other. He also looked at Heisenberg's uncertainty principle. Now, what Heisenberg's uncertainty principle says is that the amount of information that you have, now let me back up. Sorry. Heisenberg's uncertainty principle really talks about the ability to measure more than one thing. The classic example is it's impossible to accurately measure something's position and speed at the same time. Because in order to measure something's speed, we have to watch it move, right? We have to see when it's here and then when it's a set distance away from there and then time that and then measure that, and that gives us the speed. But if we're measuring the speed, we can't know exactly where it is because it has to move for us to measure its speed. So there's always an uncertainty. I can either know how fast this car is moving or I can know exactly where it is, but I can't know both. The last thing that he looked at was the law of thermodynamics, which basically says that things are always going to get more chaotic. They're never going to get simpler. If you take a closed system, it will always, always become more complex, not more simple. So what John Boyd said was, if you look at this, if you are taking all of this information, if you take all of your observations, if you try and observe the whole world around you, and you focus internally on understanding what's going on around you, the more you do that, the worse it's going to be. The more you force your mental model onto something, the worse it's going to be. Now, I said preconceived notions, mental models aren't bad. And that's true. They aren't bad as a starting place. But if you start someplace and refuse to come off of your preconceived notion, and you try continuously to make that thing fit, to make the match between what you think it should be and what is, the harder you try and push that, the worse off you're going to be. Now, again, the OODA loop can be made simple, but it's really not. So let's take and break down each of these pieces. So when you're observing, you want to use all information that you can. You want to take what's going on. You want to take outside information. You want to take your interactions with everything that's going on and use them all together to try and figure out what is real, what is going on. And it's important that we think back to the law of thermodynamics, that a closed system only becomes more chaotic. Because when we observe and we can take in outside information, we can open that system. We can gain more information. It's amazing to me the amount of emergency physicians that don't talk directly to the paramedics bringing them a patient or to the EMTs bringing them a patient. It's nuts, right? Because it's outside information. It's additional information that we can have to help us to understand what's going on. Now, there is always a problem when you open up for too much information. It is, how do we tell the signal from the noise, right? When you get on the scene of a car crash and there's 15 people screaming and yelling and dancing all around, that's probably not as useful information as the very experienced truck driver who tells you exactly how the impact went, which may be very good information. So there is a challenge when we're going to do observations, but we really want to, as much as we can, open up this system, open up our eyes, be aware of all of the little things that are going on around us to try and create what we can act on, right? And then we have to orient. Now, orienting is an act, right? We have to actively be doing this. And this is where we take all of the information that we've just observed and we put it into everything we know. Cultural traditions, our genetic heritage, our analysis of previous things, our previous experiences, our new information. It's where we take our expert opinions, our experience, our life, and we add it to what we see. And this is the challenging part for people, because you do have to make some leaps. And when you watch a really experienced EMT or a really experienced doctor or a really experienced paramedic, and you compare them to a rookie, what's the difference? I mean, I've got to be honest with you. I don't know that if a new graduating emergency physician were to come to me and say, hey, listen, can you take my boards for me? Because I'm really nervous about taking my boards. I'd tell them that they're probably a whole lot more likely to pass their boards than I would be, right? They're just out of school. They've got all the newest, latest, greatest information. But yet we value experience. And we know from lots of data that experienced providers at any level outperform new providers at any level, within certain exceptions. Why is that? Why, if this person coming out of residency has more raw knowledge, more accurate information to start with in their brain, do they get outperformed by the 5 or 10-year expert? And it really comes down to this section, right? This orientation, because there is a huge mental toolbox for the experienced person to draw from. They've seen this presentation or that presentation 100 times before. They've seen the variations on it. And so this is that step where you're going to apply your expertise. You're going to take all this information from the outside, and then you're going to kind of orient yourself and figure it out. Now, there's a couple of ways that we can orient. One of the things that we can do is we can destruct, right? We can take all of the parts of something and pull them apart, or we can induct. We can take fragments of things and create a new mental model. Now, destructive deduction is probably of the best use in medicine. I've told EMTs, paramedics, med students, other physicians, whenever there's a big problem, when we can't figure something out, break it down into a STEM question. What I mean by that is, I assume that we've all had the experience where we can't figure something out, and either we give a radio report on the patient or we ask somebody for help, and in the process, we list everything out, right? The patient is a 55-year-old male who presents with chest pain and difficulty breathing, and the 12 lead is fine. And before too long, you realize that you just named off everything to do with a PE, and that's what you've got. It took speaking it out loud. And so destructive deduction is where you can pull apart all the pieces. And what I tell people to do when you really get caught up is break it down to a STEM question. Pretend the patient in front of you, you're going to write an exam question about that person. What are the key pieces that you would want to pull in order to write the test question? Maybe their age, maybe their chief complaint, maybe their vital signs. But what if we just break it down to its basics? What are the key, what are the pieces of this that we can pull apart and list separately? Now, creative induction is a little bit different. Creative induction is, how do I put those pieces all together? And so when we're going to put pieces together, we've got to have a big toolbox to draw from, right? This is where experience in things other than what you're doing come in very, very handy, right? If you've got somebody who has worked in chemical industry and they're out and about doing EMS now, they're going to recognize gas intoxications more, right? So we start out with this big toolbox, and then we start destroying and creating these mental models. And we have to always be orienting. We have to always be looking around us, trying to fit everything together. Now, one of the things that Boyd talks about, when he talks about destroying and creating, he talks about imagine that you are a pretty adventuresome outdoors person, right? And you've been having a whole bunch of vacations. And one day you went mountain biking. A couple months later, you went skiing. And a couple months later, you were out on a lake zipping around with this boat with an outboard motor. And then you happened to be at the toy store, and your son wanted this toy tractor tank thing with these treads. And what Boyd would say is, well, wait a minute. What if you took all those together? What if you took the skis, then you took the handlebars off the mountain bike, and then you took the outboard motor from the boat, and then you took those tank treads? What would you have? You have a snowmobile. Wow, new toy. That's what we talk about when we talk about orienting. It's creating, it's taking the bits of everything that you've done and having this new mental model, right? To having this to validate this thing, to try this thing. And so that's what you do. You create this mental model. You say, okay, I'm going to build a snowmobile. or you say, hey, I think this guy has a PE, or anything. What do? You make that decision, right? You say, I think it's X. You make that decision and you feed it forward. Right? And you have to try it. So then you act. And actually, it's interesting because in the last notebook that Boyd writes about the OODA loop, he changes it. Would really throw it up is it would not be the OODA loop anymore, it'd be the OOT, because he changed act to test. But I think it speaks better as to what he really meant, right? So if we go back to this patient, we couldn't figure out what it is. Now we've gone through we observed the patient, we oriented ourselves, we decided that this was probably a PE. Now we're going to act. We throw some oxygen on the patient and they start to get better. That's the test, right? We treat for X and X seems to be a working treatment. We want to create a new sport. We took all those pieces together. We built a snowmobile. Well, now we got the snowmobile. Let's ride the snowmobile and let's see if it's the fun that we thought that it was. It is the test. It is the, how do you get to the end? What is it that you're going to do with all this information? Now, the trick to this, when Boyd was talking about it, he was talking about fighter pilots having to outduel each other, or military folks, whether it's the Marines and amphibious landings and everything else. And the tempo was always being against the other person. The idea was if I could reorient and act and decide and do all these things faster than my opponent, I could actually impose my reality on them, right? If I can turn my loops faster, if I can literally force my opponent into an action, then good for me. I'm going to win the fight. But what happens for us in medicine? What is the tempo, right? Well, the tempo is going to be guided by the case. The person's dying in front of us, we better be turning those OODA loops pretty darn quick. But if they're relatively stable, we've got more time to take in more information and to orient a little bit more and to really kind of gain things before we decide and we act. Okay, I know, bunch of esoteric crap, right? For those of you who are still awake, this is the time, or not awake, this is the time to wake up. Let's take this to the real world. Let me explain what I mean. So, patient, 60-ish-year-old Cambodian male, cyanotic, tachypnic, tachycardic, hypertensive. Brought into us by paramedics. Paramedics stated that he had been in some respiratory distress. They give him a neb. They give us a history of sudden onset of respiratory distress after inhaling some gas that was produced after mixing household cleaning products that included sodium hydroxide, chloride, and bleach. He's cleaning a drain in his bathroom, and he realizes that this gas is there and this whole family is there. So he gets up and tries to open up a vent. He gets a stool and he basically props the stool on top of the toilet and stands on top of the stool on top of the toilet, and he falls down. They don't know if there was a loss of consciousness, and EMS didn't immobilize him. Now, we heard that. This is when I was a resident. We heard that, and we activated the trauma system because, well, you know, he fell. So the first thing we did was immobilize the patient because this was 2006, and that's what we did back then. We liked that particular form of torture. We did all this primary assessment. We did our EFAS. We did our secondary assessment. We're working them up for trauma. And the quote from the chart is that, yep, he was in bad respiratory distress. So we thought he'd benefit from endotracheal intubation. So he was RSI'd. Now he's RSI'd and he's on a vent. And we get her stuck. What are we going to order for tests now? So we get a history and look back to the chart, and the guy's had a stroke. He's got cirrhosis. He's got some esophageal varices. He's had some old infections. Nothing's really leaping out here. and he's a smoker. He's got a pretty normal med list. Oops, I may have jumped ahead. And we're really kind of stuck, right? Like, okay, we got nothing. And we're sitting there, and I happen to be the senior in the emergency department that day. And I was the one who took the radio report. And when EMS called in, they'd called in and they'd said, we have a 60-year-old male with a history of hypertension and smoking who was exposed to a gas and is now having trouble breathing. And he's on medications for high cholesterol, high blood pressure. He takes an aspirin every day. And we're inbound with a X amount. And I said, and I remember saying to my colleague, hey, you know, they didn't activate this as a trauma. And the radio report, I really thought we were getting in a cardiac case. And my co-resident said, yeah, you know, so did I. You know, let's just grab an EKG. And so here's the EKG. And for those of you who aren't people who read EKGs, this guy's having a massive heart attack. And so they do an emergency cardiac cath, and this guy's got severe left main artery stenosis and severe proximal LAD stenosis, and they were able to get everything back. They were able to revascularize, and it's kind of funny because the minute that we discover the STEMI, all the trauma folks leave. They're like, oh yeah, we'll consult on him and when we're en route. And actually the tox guy who happened to be around also is like, yep, I'm out of here. We're leaving too. It's not tox, it's not trauma. The answer had kind of become clear, but the problem was the guy was no more stable. And he became hemodynamically more unstable. Eventually goes into AFib. They do a bunch of stuff, and they end up taking him in for emergency cardiac surgery. And unfortunately, he died during the recovery from that surgery. But the case had always troubled me because it took a long time for us to really get to what this guy's problem was. He'd been exposed to this gas and had a heart attack. And I'm not even sure that the two were connected. But it took backing out and kind of reorienting ourselves and saying, what information do we have? Because we couldn't get any from the patient because the patient's out. And unfortunately, the paramedics had already cruised. And it was literally thinking back and going, wow, these guys sounded like they were calling in a cardiac call. That became the key that unlocked the case. And so, again, it was a matter of taking an observation, reorienting, putting ourselves through what could be everything, making a decision, acting on it, getting the additional information, and suddenly the whole case spins. And so it's important that we look at how do we arrive at these decisions? How do we take this call where nothing is going right, where we can't figure anything out, and how do we back up and back out? And what I would say, and what the OODA Loop would teach you, is to gather all the information you can, apply it through everything you can recognize, break it down into the smallest chunks that you can, and re-put those chunks together as your experience and your tradition and everything that's your expertise tells you to do. Then ask yourself, what do you got? And move forward based on what you got. Based on what happens then, start the process over again. Make new observations based on what you just saw. Reorient, see what that information does for you now. Make a new decision and move forward again. And so the key really is to always be orienting. And that's my advice for thinking on how to think, how to have an open mind, and how to use it. I will now by chat entertain anyone that wants to make a lengthy statement, but disguise it as a question, because that's what we do at conferences, although it's a lot harder to do on this type of conferences. Otherwise, I appreciate your time. Thank you so much for coming out. I can't believe I got that done on time. Does anybody have any questions? Pulling up the chat window now.
Thank you, Dr. Mell. If anyone has any questions, please pose them in the Q&A section or window. All
right. Well, I've got nothing. I do hate to talk and run, but believe it or not, I am moving today. We take possession of a new house in about a half of an hour. And so my wife would kill me if I stuck around for this whole thing. I am willing to share the slide set. Somebody's asked if I'm willing to share the slide set via email. Absolutely. If you need to, actually, you can email me. Anyone that needs to get a hold of me for anything, I can be reached at howie.mell@gmail.com. That's HOWIE .MELL@gmail.com, or I'm on Twitter at Dr. Howie Mell. That's at DRHOWIEMELL. I'm happy to continue this discussion. Hopefully you guys found this valuable, and I appreciate everybody's time. Good luck, stay safe, stay febrile, and we'll talk later.